Welcome to Mastering and Guideline in Ultrasound and Echo.
Diastolic Dysfunction Part 1: General Concept and Measurement. Heart is the most sophisticated and amazing muscular structure. Myocardial fibers in left ventricular and almost in right ventricular, not only structurally but functionally, is a combination of different types of spring. This feature of the heart has a very specific and important role in systole and diastole. In diastolic dysfunction, left ventricle becomes stiffer and its compliance decreases. In diastole, left ventricle acts as a rubber balloon. In this cartoon, imagine left ventricle as a balloon and mouth as left atrium. For inflating balloon at any size, the pressure inside of the mouth should be higher than recoil force or elasticity of the balloon. And when the pressure in both sides becomes equal, balloon doesn't expand anymore. And at this moment correspond to the heart activity is equal left ventricular and diastolic pressure. In diastolic dysfunction, the myocardium becomes stiffer. When becomes stiffer, for expanding and filling, left atrial pressure should go higher. Let's see what happened in hemodynamic. As we know, left side is a confined and closed fluid system. So when the pressure inside of the left atrial increase, pressure in pulmonary venous increase too, and even in and will be equal to the pulmonary capillary wedge pressure, means pressure at the capillary level increased. Increasing pressure at this level causes interstitial and alveolar edema that we called it pulmonary edema. In pulmonary edema, the oxygenation disturbed, and all these changes will be detected by baroreceptors and chemoreceptors, and they send signals to the brain and causes the patient feels shortness of breath or dyspnea. With increasing left ventricular stiffness, pressure on left atrium increase too. So depending on the severity, patient may be feel tiredness at the advanced stage and even peripheral edema. The causes of the diastolic dysfunction can be categorized in three groups. First, when we have left ventricular hypertrophy. As you see, when we are going to inflate a thicker balloon, so the pressure should go higher. At the top of this group is when we have genetic problem, we have concentric hypertrophic cardiomyopathy, or when we have high afterload, like situation as moderate to severe aortic stenosis or uncontrolled hypertension. Second group are when we have some inflammatory or degenerative process in the myocardium, like coronary artery disease that cause myocardial infection or advanced ischemia, or infiltrative disease such as myeloidosis or amyloidosis or sarcoidosis. And the last group are when we have pericardial diseases and causes constrictive pericarditis. As we know, heart has been surrounded by very flexible, thin, membranous sacs we call pericardium. In this situation, the pericardium stiff and very stiff, even though the myocardium may be normal, has normal structure and function, but the stiff and rough and hard pericardium doesn't let heart expand easily during diastole. Based on the mechanism, heart failure can be divided to groups, systolic and diastolic. In systolic failure, the pumping has problem and heart cannot eject blood effectively, and we called it heart failure with reduced ejection fraction. Another group is when we have only diastolic dysfunction. In this group, the pumping doesn't have problem and ejection fraction stay at normal level, and we called it high heart failure with preserved ejection fraction. Cutoff for this classification for EF or ejection fraction is 50%. As a general rule, but not always, in systolic failure, left ventricular volume and size usually increases and becomes dilated. In diastolic dysfunction, left ventricular volume usually is normal or even less than normal. Based on new guideline on 2016 by American Society of Echocardiography and European Association of Cardiovascular Imaging, for evaluation diastolic dysfunction, we have to measure 4 parameters: mitral valve Doppler, mitral valve annulus tissue Doppler, tricuspid regurgitation velocity, and left atrial volume index. In some specific situation and cases, we have to go and measure other parameters, including pulmonary vein Doppler, IVRT and IVCT, E deceleration time, velocity progressive, T index, and sometimes strain study. In mitral valve inflow Doppler, after we get in nice and correct apical four-chamber and determine where are the tip of the mitral valves, leaflets, we put sample volume between those tips and hit pulse wave Doppler bottom. Sample volume size is better be around 2 to 3 millimeter and sweep speed between 25 to 50 millimeter per second. In those cases that heart rate is very high and waves fuse together and we don't have very clear border between them and detail is not clear, we have to increase sweeping speed to 50, even 100. In the cases that we have extra beats too much, like multiple premature ventricular contraction or AFib, and even in situation that we need evaluate respiratory variation, like when we have pericardial effusion, we have to decrease sweeping speed to 25 millimeter per second. For optimizing Doppler image, we have to decrease the gain until the background doesn't have any noise and is black, and for wall filter should be around 100 to 200 megahertz. With diastole start, the pressure in left ventricular becomes below the left atrium and the blood suddenly rush and will be sucked to the left ventricular. In that case, since the blood goes toward the transducer, it gives us a positive shift that we called it E and represent rapid feeling or passive feeling. After E, the blood pressure in both sides, left atrium and left ventricular, becomes close to each other, and so the blood flow to the left ventricular decrease, even stop. To this phase we called it diastasis. almost at close to the end of the diastole correspond with P wave. After P wave, atrium contract, and in that case, the blood again is pushed to the left ventricular, and it causes second positive shift that we called it A wave and represent atrial contraction or active phase of diastole. For determining the waves, we shouldn't rely on the shape of the wave, and almost always correspond those waves with EKG. As we know, E start right after T, and A start right after P and end right at R from QRS. For measuring E and A wave, we have to find a good curve that has clear border and doesn't have spike and blurring part. And even if you notice, here we have different shape of the Doppler and mitral valve. And here the E and A are fused, and here they are separate, and so on. We know that mitral valve inflow is preload dependent factor, means with the changes of the heart rate or blood volume, like when the patient respirate, the inflow will change, and the Doppler changes a little too, as you see in these four different envelopes. We go and find the one that has almost average shape and has clear border, strong border, and is not at the PVC extra bit or the pulse right after PVC. We don't measure those spots. When we measure E and A on the calculation from the machine give us the E to A ratio. The normal cutoff for E to A ratio is between 0.8 to 2. Whenever in echo you have a wide range of normal, always should think about other factor too. For example, when we are dealing with a very young and athletic patient, E to A ratio 0.8 or 9 even is in the normal range, but we have to think a young and athletic person should have very elastic and soft left ventricular, and expanding shouldn't have problem that cause this low E to A. So we have to put more attention in other detail and make sure the patient doesn't have any problem. For measuring deceleration time, we have to measure how long it takes E maximum drop to the zero. And so very easy, we put one caliper at the tip of the E and another one over the zero line correspond and parallel to the E slope. So the machine calculates for us deceleration time. In those cases that E slope is very low, is not sharp low, and they fuse and we don't see end of the E, in these cases we have to always finish the endpoint on the zero line. I noticed even some cardiologists, they finish it E slope at the end of the A, and that is not right. As you see here in this image, this measurement is not correct. We have to start at the E peak and parallel to the slope and continue until it meets the zero line. In that time, our deceleration time will be this amount, not here to here. In some cases, we have an extra positive wave between E and A that we called it L wave. Most of the time represent some kind of diastolic dysfunction, but most of the time, not all the time. In young and athletic with low heart rate, maybe we can see L wave too. Another measurement that we have to measure on mitral valve inflow Doppler is A duration. A duration, when A start and when it finished. It start right after peak of the P and end at R. For mitral valve annulus tissue Doppler, after we get in four-chamber view and selecting tissue Doppler or TDI, we put sample volume 1 in the medial annulus at the cross of the heart, and next time we put it at lateral annulus of mitral valve. Sample volume size should be around 3 to 5 millimeter. In those cases, we don't have a strong Doppler, we can add it up to 10 millimeter. The tissue Doppler of mitral valve annulus has a specific pattern. When systolic start, the base of the heart or mitral annulus move toward the apex, so it will give us a positive Doppler shift. Here we called it S prime. With ending systole and starting diastole, base of the heart suddenly drop down and goes away of the apex or transducer. So it gives us the first negative Doppler shift. We called it E prime and correspond with E at the mitral valve inflow or rapid filling. At the end of the diastole, again, one more time, annulus of the mitral valve drop 2, again give us the second negative Doppler shift wave, and we called it A prime. We measure usually only E prime in the mitral valve annulus tissue Doppler. For measuring, we have to go and find the one that has clear and sharp peak, and we don't include the spike or blur part. The easiest way is that we follow these two lines, two rim, and see where they meet each other, and this spot will be our E prime velocity. The normal E prime velocity for medial is equal or more than 7 centimeter per second, and for lateral is equal or more than 10 centimeter per second. When we measure E prime, E and E prime, machine calculate for us E to E prime ratio. In normal, it should be less than 14 when we measure average. In other words, we measure medial E prime and lateral E prime. If we use only medial, the ratio, the normal ratio will be less than 13. If we use only lateral tissue Doppler of mitral annulus, the ratio, normal ratio cutoff will be 14. Another parameter that we can measure in mitral valve annulus tissue Doppler is IVCT or isovolumetric contraction time. As its names give us, is the time that myocardium and left ventricular start contracting, but the valve are closed. So it starts right after R, as you see here, and we will see a spike here, a spike at the Doppler, and represent closing mitral valve. And the second clicks or spike is aortic valve opening. the time between these two opening, closing and opening valve is IVCT. Another time that we measure in tissue Doppler mitral valve annulus is IVRT, or isovolumetric relaxation time. That is correspond to the end of the systole. At the end of the systole, or S prime, again we will see a spike that represents closing aortic valve and then opening mitral valve. So the time between this closing aortic valve and opening mitral valve is isovolumetric relaxation time, and is right between before E prime and after S prime. And the time between these two is ejection time, and with measuring all these three parameters, we can measure TAE index. For IVRT and IVCT, we can measure them in Doppler 2. For that purpose, we go get apical between apical 4 and 5 chamber, and we put sample volume between mitral valve and LVOT, because we are going to detect both mitral valve inflow and LVOT outflow. So we will have both Doppler for the LVOT, negative shift, and positive shift for mitral valve. Or we can put it continuous wave, just put cursor between these two, mitral valve and LVOT, so we can get both Doppler. And IVCT will be after end of the A and before starting LVOT. So this time will give us IVCT. And IVRT is right after LVOT Doppler and before starting mitral valve inflow or E wave. So, and this time we measure at IVRT. For left ventricular, left atrium volume index, we have to measure it in two views, 4-chamber and 2-chamber. For measuring left atrium, always we have to keep in our mind that atrium shape is almost rectangle or oval close to the round shape. So if it's not, and your tracing doesn't give a smooth curve shape, most probably you don't have right image or you are measuring wrong way. In this measurement, we shouldn't include a pulmonary vein, and here you will see left atrial appendage. At the end, when we trace the left atrium, the machine gives us an option about long axis of the left atrium, this line, and you can change it, make it, move it around to the left or right. You have to try put it this left atrial axis, long axis, make it parallel, perpendicular to the mitral annulus plate. So when you trace it and finish it, try make it this almost perpendicular to the mitral annulus plate. The normal cutoff for left atrial volume index is equal or less than 34 milliliter per meter cubic. For measuring tricuspid regurgitation velocity, we have to go get it a 4-chamber view and put it continuous on the jet. If our cursor is not parallel to the direction of the jet, we have to go off axis and try to make it almost parallel. Otherwise, always we measuring less than normal, or we underestimating. If we cannot do it in one view, we have to go and measure in all other view for TR, like the plaques or PSACs or even subcostal. Whenever or whichever of them are highest, we take it that one in our evaluation. For measuring, always we have to go and find the border peak that has clear border and is not fading spot. The fading spot or blurring, we don't include it. We go the spot that is very clear, sharp, and strong. Pulmonary Doppler. For pulmonary vein Doppler, we go get it 4-chamber view and try find the blood comes from pulmonary vein as you see in this clip. If we cannot get it, just try angle or fan up or down until you see the pulmonary vein, or even sometimes increase your color gain or decrease color scale. And finally, when you saw the pulmonary vein completely, put sample volume 1 to 2 centimeter inside of the pulmonary vein and hit the pulse wave bottom. During systole, here as you see, during systole, the annulus or base of the heart move toward the apex, and so left atrial elongate. With elongation of left atrium, the pressure inside of the left atrium decrease, and so blood goes suddenly from pulmonary vein to the left atrium, and it gives us a positive shift as you see here, and we called it S, that represents systolic phase. On diastole, when the diastole starts, blood goes to the left ventricular, and again pressure dropped, and when the pressure drops in left atrium, one more time blood rush to the left atrium from pulmonary vein, and it gives us second positive shift, that is, we called it D wave. And if you notice here, S represents right after QRS complex, and D at the diastole time after T wave and before A wave. And the third wave is AR. AR represents exactly the time of the atrial contraction. When atrium contract, blood goes toward the left atrium, but the contraction forces the blood to all direction, toward the left ventricular and toward the pulmonary vein. So with atrial contraction, there is a force against the pulmonary vein, blood flow goes to the left atrium. It gives us a negative shift in the Doppler. And we measure peak of the AR and duration of AR. Just for this measurement, again, always correspond with the EKG. I hope you liked this lecture, and if you thought it was useful, please share it. Up to next time, have a wonderful time.